Hi, my name is Joy. I'm a clinical anatomy research fellow here at the Seattle Science Foundation, and today we're very lucky to have Dr. Michele Arnold with us. She is a neuromuscular physiatrist here at Swedish Medical Group. Thank you for having us.
My pleasure.
So I just have a few questions for you. So I'd like to start out really broadly. So going through medical school, I didn't really get that much exposure to physical medicine and rehabilitation. So I'd like you to kind of elaborate on what the field is like and what types of patients and pathologies that you see.
Sure. Physical medicine and rehabilitation is not a new specialty. We've been around since about the late 1930s, early 1940s. We came to be known for rehabilitation of war victims when they came back from World War II. And so that was kind of the dawn of physiatry, as it's called, or physiatry on the East Coast. And physiatry involves use of physical medicine agents like heat, ice, massage, physical therapy, electrical stimulation as a tool, much like medications, injections, and surgeries are a tool that we use to treat patients, which today has become very timely. Many of our patients don't necessarily want medications for some of their conditions, and these provide a nice alternative, and they're evidence-based. A physiatrist would treat patients who have functional limitations or disabilities, so a stroke patient or an amputee, someone with a spinal cord injury like paraplegia or quadriplegia. Patients who've had multi-trauma, multiple fractures, and just are medically complex and deconditioned. A physiatrist might be the doctor who cares for those patients in a rehab unit after their acute care stay. But we also have physiatrists that are in the outpatient setting that care for patients with musculoskeletal and neurologic conditions that are in ambulatory clinics. So we do joint injections, and we partner with the physical therapists and the occupational therapists and our speech language pathologists to form a rehab team around patients who have functional limitations. But we also do non-surgical orthopedics in a way. We don't operate on patients, but we can treat musculoskeletal conditions without surgery.
Can you tell us a little bit more about those types of treatments? Like what treatments do you do outside of surgery?
Sure. So procedures that are common to physiatrists are obviously physical exam skills. That's not a procedure, but a physiatrist typically gets a lot of education in the musculoskeletal physical exam of the spine, the joints, the muscles, the tendons, and the nerves. And so we also learn a lot of internal medicine in our training, but it's much more geared toward musculoskeletal and neurologic. And so I like to call myself an externist. I'm kind of the opposite of an internist. You know, I'm not treating your heart or your lungs or your kidneys, but treating kind of neuraxis and appendages. So procedurally, we can do various types of injection treatments, like trigger point injections, which are just local anesthetic injections into areas of taut muscle or taut muscle bands. We also do joint injections, tendon injections, nerve blocks. We do electrodiagnostic studies, which is EMG and nerve conduction studies. Many physiatrists work in pain clinics, and so they can do fluoroscopic guided epidural injections, SI joint injections, facet joint injections, and some of them in pain clinics do spinal cord stimulator trials, sympathetic nerve blocks. We also are venturing into the era of regenerative medicine using stem cell therapy. So there are many physiatrists who are offering platelet-rich plasma injections for joints and tendons, and also some stem cell therapies.
Wow,
Yeah.
There's a lot of innovation going on. So one thing that I was a little bit unclear about was how do you differentiate between neurology patients and PMR patients? Like where is the line, or is there a line, or do you often collaborate?
That's a great question. So there is a little distinction, but we do team up with our neurologists. On the inpatient side, the neurologist might be the one that sees the patient in the emergency department with an acute stroke and gets TPA going for a stroke. They get them admitted to the ICU. The physiatrist often comes after that initial acute phase, and we help manage some of the potential complications of stroke, like spasticity or weakness. We partner with physical therapy and occupational therapy and can help guide our therapists to treat certain components of that stroke. And then there's a handoff where the neurologist gives us the baton and we kind of run the next leg of the race, take them to the rehab unit, and then we often follow them as an outpatient. And so we deal more with the functional limitations. So the neurologist might prescribe a medication to manage their blood pressure to prevent a second stroke, whereas I might prescribe the leg and foot brace to address the foot drop. So it's a little tough to guide a medical student as to where that dividing line is, because now we've got physiatrists who do neuromuscular medicine like I do. It's a newer subspecialty, and so a neurologist or a physiatrist can sit for the neuromuscular exam. So there's much more overlap in that arena than there used to be. And for the most part, neurologists are still managing central nervous system disorders, whereas a neuromuscular physician manages the peripheral nervous system.
I see. Okay. And yeah, I did notice that you have quite a few certifications. You have neuromuscular medicine, sports medicine, spinal cord injury, and electrodiagnostic medicine. So can you tell us a little bit more about why you decided to do those? And
Sure.
Yeah.
When I first came out of medical school, I was in a very small town in western Nebraska, and they did not have a lot of subspecialty practice there. So I felt really compelled to fill in the gaps since we had no subspecialists. And the spinal cord injury medicine was always a passion of mine because of a family member who was quadriplegic. So I elected to go ahead with that exam. I was able to sit for that exam without a fellowship because it was still in its early stages. And then for sports medicine, that was actually very similar, that you did not have to do a fellowship in order to sit for the sports medicine exam. Neuromuscular medicine, since it's brand new, is another opportunity. So I was able to demonstrate competence in those areas through examination without having to do a fellowship. I think most medical students would also want to know that getting certified by just a board certification exam doesn't necessarily give you that patient repertoire. You have to demonstrate that you see a higher enough number of patients with those sorts of conditions to demonstrate to the board that you have mastery of that subject. And so that's a challenge, but the unique setting where I practiced gave me the opportunity I was the only one that took those on, so I was able to manage it. It was a really unique opportunity to be able to sit for those.
Okay. And can you talk a little bit more about the electrodiagnostic medicine? I'm not too familiar with the treatments available and what it's currently used for. I was wondering if it's possible to use it as a preventative tool for someone who's elderly and not able to exercise and use their use their muscles to their full function. So is it possible to use it as a preventative tool to prevent atrophy?
So that's a good question. Electrodiagnostic medicine is a tool used by typically neurologists and physiatrists. It's a diagnostic test. It has two parts, and the first part involves placing electrodes over different areas where you wish to test peripheral nerve function. We provide an electrical stimulus to the nerve and then measure various parameters of that nerve's function, specifically the latency or timing of the nerve signal, the amplitude or the amount of signal getting through, and it gives us information about myelin and axon so that we can render a diagnosis like carpal tunnel syndrome or cervical radiculopathy or myopathy. So the first half looks at the peripheral nerves. The second half involves putting a fine wire needle electrode, which is kind of like a medical antenna, if you will, a tiny little wire antenna into skeletal muscle to record what are called the membrane potentials of skeletal muscle. Diseased muscle has certain electrical manifestations of that disease, and that's what we can tell when we put a needle into a muscle. And so it's really a diagnostic tool for any pathology of what's called the motor unit, anywhere from the anterior horn cell of the spinal cord to the nerve root, to the plexus, to the peripheral nerve, to the neuromuscular junction, to muscle. Outside of that, electrodiagnostics don't provide any useful diagnostic information. So I can't tell you about your disc or your tendon or your joint, but I can tell you about your peripheral nerve, your plexus, your neuromuscular junction. So it really doesn't have a lot of utility for preventative medicine.
Right.
There are other electrical applications that people might use, like functional electrical stimulation. That's placement of surface electrodes and then delivering an electrical stimulus to underlying muscle or nerve. Unfortunately, it's there's so many different nerves and muscles that you would have to stimulate in order to, say, prevent the normal process of loss with aging, which we call sarcopenia.
Okay.
That it would probably not be terribly useful. Right. Although I've never investigated. I'm curious whether they have certain electrical stimulant devices in the suits of astronauts.
Oh, okay.
It makes me wonder, because there are some bone benefits to electrical stimulation. So there may be some applications in the aeronautical medicine, but
okay.
I've never read up on it.
Okay.
So.
Okay. And I was curious to know what your views are on integrative medicines or / alternative medicine, such as acupuncture and myofascial massage. Do you think there are any merits to these types of treatments, or what are your thoughts on that?
So integrative medicine and functional medicine have been kind of recent developments, and I'm no expert, but integrative medicine looks at the gut biome and looking at celiac disease and other food intolerances that might be manifestations of global disease. They also look at different like yeast imbalances. They focus on immunologic triggers for general disease and nutritional aspects of medicine. And so they tend to run a little bit countercultural to Western medicine. I think there's definitely some science there, and ultimately I expect that there will probably be some meeting in the middle. As far as acupuncture is more of an alternative medicine approach. It has potential benefits for various pain conditions and maybe some spasticity type conditions. Typically, it's considered an alternative medicine approach, and so often becomes more of a last resort for a patient who's not had success treating their pain with other attempts. But response rates are around 40%, which means that's potentially better than placebo. And compared to some of the other treatments that we may offer, I mean, surgical spine surgeries have fairly low success rates in the long run, and so in some of these settings, a trial of acupuncture may be warranted as long as there are no contraindications.
I see. Okay. And so what about myofascial massage? Do you have any thoughts on that?
So that's a good question. Myofascial pain has had controversy, but kind of dates back to the early 1960s when two pioneers, Doctors Travell and Simon, published a 2-volume textbook that sits on the shelves of many physiatrists that describes myofascial pain. And the concept of myofascial pain is that we get trigger points or areas of knotted, taut muscle that produce local pain and radiating symptoms. And many of us have them. In fact, maybe this is not a disease, it's just a condition associated with muscle stretch, overstretch, like from poor posture, or muscle injury, like from a whiplash. And if you've ever gone up to a loved one and given them a little neck massage or shoulder massage, sometimes you found a little knot in their muscle. That's myofascial pain. So there's not much mysterious about it, but I think myofascial release is a technique where various mechanical forces are applied to a trigger point in muscle, often by a physical therapist or a massage therapist, to try and alleviate those bands. Often it provides excellent temporary benefit for local pain and radiating components associated with myofascial pain. The downside is that unless you correct those postural imbalances or that muscle overstretch or whatever is the cause of that trigger point, chances are it's going to come back.
Right.
So,
do you think there's any potential for damage for say a person is not really knowledgeable about the techniques of the massage? Is there any danger or risks involved with the massage?
So massage has indications and contraindications, and obviously local infection in an area with massage, you may not wish to provide additional pressure. Lymphedema is another example. If there's a fracture or a missed diagnosis, those would be kind of the biggest risks. Probably the other common side effect, not really a risk, but a side effect of massage is, sometimes they get into areas where you create a little flare-up. If you get into a muscle area that you're not having pain and someone messes with it a bit and gets into some deep tissue massage or overstretches an area, you can flare up. And I don't know if you've ever had a massage, sometimes you're a little sore the next day. For the most part, there tends to be low risk of tissue damage as long as you stick to those contraindications.
I see. Okay. And one of the questions that I always love to ask people or attendings that I've worked with is, how did you get to where you are, and how have you felt about your journey so far, and where do you see yourself going in the future?
Great. Oh, that's a good question. I could tell my life story.
Yeah, exactly.
I think influences in my youth, having witnessed my grandfather being in a halo fixator after he broke his neck, and then being at his side as he kind of bared the burden of quadriplegia for many years before he died, it inoculated me with rehab medicine, because I sat on the mat next to him in the rehab gym as they worked on balance, and I saw his attendants helping him in and out of his wheelchair. I was sad that he couldn't go back to fly fishing and that he wasn't able to drive a car anymore, but I saw also that he was still able to live at home, and he could get in and out of his house and could still get in and out of a wheelchair van, and that was back in the 80s. So that, I guess, kind of stuck with me. I actually thought I was going to be a physical therapist. And so I volunteered initially while I was in my undergraduate years at a physical therapy facility, and then got a job as a physical therapy aide. And it was an occupational therapist that told me about physiatry. And I thought, I'm going to go to medical school to be a physiatrist. And when I applied, I think I was the first physician in like 20 years at my medical school that said, I want to be a physiatrist. And I think on my application, they were like, you want to be a what? And so I felt like all 4 years of medical school, I was educating the people around me, what's physiatry? And so it was not a hard choice to find a specialty, because I already knew that I loved it.
Right.
The hardest part was stepping into residency. A physiatry PM&R program is 4 years, and that first year is usually either a transitional year or there's a fair number of internal medicine, which was not my passion, hence the externist claim, right? So I think that was the hardest part. There were some dark months of rotations that I felt didn't really apply to me, and I'll be perfectly honest, in medical school we got to that chapter on the glomerulonephritis. Do you remember that chapter? Yeah. I looked at it and I thought, it was the first time in my educational experience where I looked at it and I said, I'm not going to read this. And I didn't, and I'm very thankful for my nephrology colleagues. It was like this moment of, I'm putting up the white flag. I'm not even going to learn this. It was maybe a little shameful on my part, but there's only so much that sometimes that you can kind of memorize and cram in there. And I just decided glomerulonephritis was the line. That's where I was drawn in. So the match was a difficult process, I think, partly because I wanted to stay close to family, and so I wanted to pick a good program that was close to my family, and I was really pleased to get my first choice. And once I got into my program, I had a mentor, and he was not the friendly kind of mentor that pulled you aside. He was a little corrosive, but brilliant guy, and he got under our skin a little bit and pushed us to be better. And I'll never forget the day, he was the one who taught how to do electrodiagnostic medicine, and so I think that's why that's a passion for me, is he kind of ignited a flame. But I'll never forget, there was a day when he said we'd meet one-on-one. He offered this to every resident, and he said, you need to read something in my book. He wrote, a big book on electrodiagnostic medicine. It's like 800 pages of just EMG and nerve conduction studies and neuromuscular stuff. I mean, all the way to like electrophysics, and it's pretty meaty. But he said, you read something and I'll sit down with you for an hour and we'll go over any questions you have. Wow. So I cracked the book the night before, right? And got into the chapter. Right. Got into the chapter on neuromuscular junction disorders, which are really complicated. Things like myasthenia gravis and botulism and Lambert-Eaton myasthenic syndrome. And I got through 100 pages that night. I went to bed proud. And I showed up the next morning, and we got started, and he started asking a few questions. He's like, "You didn't finish reading that section," and he gave me hell about it. He did. He said, "Here's what I'm going to do. I'm going to give you a spoon for graduation. No, I'm going to give you a ladle so that I can spoon feed you for graduation." I felt so lousy, but he spurred us on to make us do better. To this day, I hate junctional disorders. Thanks to that.
Okay.
But I had an opportunity after residency to, with my first job out, I wanted to, I was open to going wherever I wanted, and my family was mobile at that point, and I found a place that paid off my medical school loans, which is rare for a physiatrist.
Yeah.
I was supposed to stay there for 3 years, so they'd pay off my loans. I stayed for 10. And again, some really good mentors gave me opportunities to excel and to lead. And they gave me leadership training. And so I had some opportunities to serve at executive levels that I wouldn't have had if I hadn't been in that little small hospital.
I see.
And it was a unique opportunity. So don't negate the opportunities at small hospitals. Sometimes it gives you a chance to lead in an environment where you have support and they're willing to invest the time and the money to grow you. And then when it was time to move, it became much easier to step into leadership roles here in the big city.
I see.
So,
And where do you see yourself in the future? Do you see yourself staying in Washington, or?
I probably will. I'm one of those annoying people that moved here and I'm jacking up the cost of your homes and making your traffic worse. So we love the Pacific Northwest. And I've got two girls in 8th and 4th grade. And so we're going to hunker down for, we're going to get them
For
through.
the next little while.
Yeah. Plus the educational opportunities are outstanding here. We've got the University of Washington and many other educational opportunities. Even if our kids decide not to go to UW, if they go to CSU or elsewhere, I feel they'll get a great education here in the state. And so even if they don't do medicine.
Okay. Well, do you have any other advice for future medical students who may want to pursue physiatry?
I do. Find some volunteer opportunities so that you can see it in action and talk to someone who's living it so that you know how much burden is it. Every specialty carries joy and burden. And the burdens in one specialty may be more bearable than the burdens in another. Or the joy in one specialty may be so much that it outweighs the burden. And so find that mix for you, and don't forget to be a person. Connect with your patients. Connect with them on a way that nobody else connects with them, and they will respect you and trust you. Don't forget the human piece. So.
Thank you very much, Dr. Arnold.
You're welcome.
It was nice meeting you, and
Thanks.
we appreciate your time.
You're welcome.
Thank you.